welcome everyone to this patient partnership webinar series on transition. So this is the first webinar of this series. We are going to have another one tomorrow. And my colleague Nora is the brain behind this series of two webinars, and we hope to give you a little bit of an overview of what's going on in this area in this during these 2 days. So let's go through the agenda briefly. Housekeeping rules. Sometimes we forget about this. So yes, please mute your micros and turn on your camera if you can. And your name. You can raise your hand if you want to speak, or you can also use the chat box if you have any questions or comments. And we're recording this meeting because it was kind of a popular webinar, this one. So we got more people than the capacity of the Zoom. So yeah, can you? Can you go to the next slide? Okay, so the agenda for today is kind of packed, but we're aiming at covering some of the more high-level things regarding transition today, and tomorrow we'll go more into some of the specific projects that some ERNs have developed already. So today, Nora will give you a little bit of Nora Lázaro, who's my colleague. She will give you a little bit of an introduction to the topic. And we've also invited Wiebke Papentin, who is the EPAG lead for ERN Liver. And Wiebke is going to explain to you an initiative she's launched herself to establish an ERN across ERN patient group on aging with a rare disease. So these webinars on transition are focusing on transition from pediatric to adult care, but we acknowledge and we consider that other transitions are as relevant. And so we found out that Wiebke was launching this group, and we thought it would be a nice opportunity for her to explain to you what she's aiming at with this working group. Then we'll have Aurora Buergi, I'm not sure if I'm saying that surname correctly, and Jane Sukins from ERN Liver again, and from the youth panel, and they will be explaining to us what this youth panel, which is across ERN youth panel, is doing on transition. Then we'll have a little bit of time for questions and answers, and I'll take over to describe a little bit what is happening in the area of measurement and transition pathways. And then Eduard Pellicer and Esther Lazeras from the Sant Joan de Déu hospital in Barcelona will explain to us how they're measuring, what indicators they're using to measure the effectiveness of their care pathway, transition care pathway at the hospital. And finally, we'll have a little bit of also time for questions and answers, and Nora will wrap up. So without further ado, I think I'm going to give you the floor, Nora, and I'll mute myself. Thank you, everyone.
Thank you very much, Ines. If you can just check the email, I've sent you something because Jan and Aurora, the next speakers, cannot join. So please have a look to that. Thank you.
No, we're here.
Perfect. Thank you so much. Great.
You're muted.
Nora, you've muted yourself.
Yes, now I'm okay. Thank you so much for that. So yeah, I wanted to make an introduction of what are we looking at today with this series of webinars. So transition is often associated with the move from pediatric to adult healthcare. However, for people living with a rare disease, transition is a lifelong reality. So we wanted to acknowledge that in this series of webinars, because patients, they move between different service, care settings, and life stages. It can be from childhood to adulthood, pediatric to adult care, from GP to specialist center, maybe to palliative care. So transition is a continuous process that spans the entire life course and requires coordinated support across health, social, educational, and community systems. Well, these transitions may look different. They often share common challenges from the patient perspective. We hear fragmented care, loss of information, or unclear responsibilities in the different healthcare teams. Heavy coordination burden also placed in the patients and the families. Despite progress, people living with rare disease continue to face these common needs and challenges across transitions. And addressing this has been also a key priority identified by the European Patient Advisory Group, the EPAC Steering Committee, in 2026. We have to acknowledge that a lot of progress has been done by the European reference networks. Most of them have done extensive mapping of the barriers and challenges, particularly in the transition from pediatric to adult care. And we will see later also the setup of the ERN Transition Working Group and their work. And they also developed several recommendations on transition. However, we still see that other transitions, different to the pediatric to adult care, are still missing in the pictures. We also see no structure or coordinated approaches, and that good practices still remain more like silos at center level. So after seeing this, we know that transition requires actions at different levels. And this slide is actually inspired in micro, meso, and macro levels identified by Jan Swiekens and Karsten van den Kingaert in 2025, and also some discussions that we had around Jardan Care Pathway Working Package 6 on care pathway, which identifies 3 different levels: the micro level, the meso level, and the macro level, because we have stakeholders and we've tried to map here the different stakeholders. It's not a close list for sure, because at micro level we find the clinical and social care, which they need to deliver person-centered care, co-create transition plans, and ensure continuity. In here we may have the parents and caregivers, the pediatric healthcare teams, the adult healthcare teams, and other health professionals, psychologists, physiotherapists. We also have the meso level. This is the organization, the survey design, and delivery. And the objective is to design a structured pathways. So also have joint clinic governance and monitoring. If the transition is working well, we can have here the hospitals, quality and patient safety departments, rare disease expert centers, rare disease resource centers. And then finally, we also have the macro level, which is about the national strategy, policy and health system, funding and scale up. It's about setting policies, fund system, secure human resources, and define standards and scale up. So in here, we will have the health ministers, national, regional levels, social health insurance funds, patient organizations, etc. So we need to understand that successful transitions are not the responsibility of a single professional, department, or individual. It requires coordinated action across the entire ecosystem at the clinical, organizational, and policy levels. How to fulfill these gaps that we've mentioned before, the challenges and the needs? Well, this webinar series builds on the work of some of these actors and focuses on how to translate recommendations into practice, with a strong emphasis on 2 main things. One is patient partnership, and the other one is the use of indicators to support the implementation and the scale up of these recommendations and good practices. With this, I would like to give the floor to our first speaker. We are very glad to have with us today Dr. Vivke Papentin. She is patient representative, volunteer, and EPAC lead in ERN Liver, and also she is member of the ERN of the German National Alliance for Rare Diseases. So Vivke, the floor is yours, please.
Yeah, thank you for inviting me, Nora. Next slide, please. I just would like to report you about our initiative. At the last AXE, the National Alliance of Germany meeting, I moderated a workshop about patient journeys, and it turned out that 90% of our member organizations had never heard about patient journeys. This shocked us quite well, and especially for me as a patient in the Wilson disease area who developed this patient journey years ago, I asked myself what's happening. And as it helped me very much to have this patient journey, next slide, please. I just remembered aging is a part of our lifelong patient journey, and as we have earlier diagnosis and better treatments, patients live longer. And the problem that we see is there's no research and very few knowledge about the problems patients face in later age, especially related to their rare disease. I, as a patient, made this experience with my professionals, and when I asked the others, everybody told me, yes, where's the problem? So open questions we as patients have are what's happening in menopause and andropause, what are the long-term effects with drug treatment over decades? Is there any interaction of other treatments for other diseases? And is there an impact of time of diagnose? What's happening in the age? Next slide, please. In our group, we can say we are happy that there are many people older than you would think, and this number is increasing. Next slide. We therefore did an analysis, and as you can see, at the moment, in about more than half of our patients are older than 40 years, and in 10 years, 2/3 of our members, and they are all Wilson patients that we have in this graphic, will be older than 50 years. So there is an upcoming problem. And lack of information. Next slide, please. The question that we ask ourselves is, are long-term stable patients perhaps treated outside centers? Because when we raised the topic aging as patients in the ERN Rare Liver members meeting in February, it became very clear that the clinicians there regarded diagnosis and initial treatment as most important. Aging with a rare disease was not considered as a significant issue. Next slide, please. So then I decided to contact all EPAC leads in spring. There were only few that responded, but amongst them Graham, who is also here. He's one of the longest surviving persons with esophageal atresia, and he is a board member of Eurodis. And we both decided to promote this subject. With a group of 5 persons, we started meeting monthly and then decided to promote the topic at the ECRD in Prague, and reached out to people and found like-minded individuals who are committed to this largely unexplored subject. Amongst them, Simone Louise, who is steering committee chair of our EPAC lead steering committee. Next slide. Ideas and possible activities to push the idea forward are quite difficult. We agreed from the start that we should form alliances among representatives of conditions that share the same needs in order to save our energy and time. And the ideas we discussed were patient-driven survey in all 24 ERNs on patients' needs to find out overlappings, and perhaps to follow patient-induced science. Open questions could be, in rare disease, we often have to explain our rare disease, but what happens when mental capacities reduce? And another question would be, what happens when the general practitioner comes to care homes? How do they get informed about our needs? Because usually we explain it on our own, but if we are not capable anymore, who does it? Next slide, please. And this is why I would like to talk to you about transition from adulthood to old age. And if you have the time and if you think this subject is worth talking about, we would be very happy if you join us on July 8th at 17 o'clock Berlin time. And I could send you the Zoom link if you contact me. The email is below. So thank you for your attention.
Thank you so much, Vivki, for sharing this information. Any immediate reactions or questions for Vivki? Because I know she needs to leave to the... I see many clapping hands. Okay, so note down her email in case you are interested. We will now give the floor to our next speakers. We have Aurora Burgi, we have Rita Fusenegger, who unfortunately sent her apologies, and we also have Jan Swiekens, and they will speak about the ERN Youth Panel and also the ERN Transition Working Group and the latest workshop that we had on transition in Ghent this year. So Aurora, Jan, the floor is yours. Do you want me to share slides or do you prefer to share it yourself?
For me, you can. I only have
okay.
So it's for me, it's okay. Hello everyone. I'm Aurora Burgi. I study health sciences and technologies at ETH with my idea to then study public health as a master. So when my mom told me that they were searching young people for the youth panel, I joined because I was really interested. Yes, next slide, please. Rita and I, we're from the youth panel. The youth panel was created to give young people like us a voice to represent ourselves in healthcare discussions and project or policy development. Our goals are to empower young people with rare and complex diseases to advocate for their needs. And we give young people a shaping role in the ERN initiatives. We try to address challenges right now. It's the transition from pediatric to adult healthcare. And we also try to create a network of young people who can share experiences and so improve healthcare outcome across Europe. We are also into spreading awareness, obviously, so that young people can talk more about it, and we try to represent us at European level, which is also sometimes hard, as you also might know. And yes, this is who we are. Janne, I pass the microphone to you.
That's great. I will share my slides because I have a little more, I think. There we go. Is this moving? Yeah, great. So Nora already introduced the topic wonderfully, but so I will be talking about the transition from pediatric to adult care. Often we kind of make the distinction between transfer and transition, where transfer is the actual moment where these adolescents kind of transfer their care to adult care, and then transition is everything surrounding that. It is a process. It is growing up with a rare disease and then trying to navigate life. Now, Nora already mentioned the ERNs. For those of you who are not familiar, I think most of you will be, but very shortly. So the European Reference Networks are virtual cross-border networks. They were founded back in 2017, and they involve healthcare providers and patient representatives from all across Europe with the main aim of kind of gathering the knowledge and expertise on rare diseases. And so there are 24 of those. I'm mainly affiliated with the ERN Rare Liver, but so kind of every disease group you can think of is part of one of these groups. So as I said, I'm part of the ERN Rare Liver, which is the rare disease network for liver diseases, and to share, care, and cure. And just to kind of make it a little clearer, because I think it's always a very vague concept for those who are not familiar. So a hospital can be a member of an ERN. And so this is the example of ERN Rare Liver, where there are 52 hospitals across Europe who kind of collaborate and think about how to improve the care. But back to all the ERNs together. So towards the end of 2024, we figured that there are some topics that are transversal, so relevant to all rare diseases, with transition being one of them. So we founded the ERN Rare Liver. Something's going wrong on the screen. The overarching working group. So we have 2 representatives per ERN and representation of all 24 ERNs. And so right now we've been doing monthly meetings, alternating between a meeting with the core group and a meeting with everybody. And we always share kind of, there's always 2 or 3 ERNs that share their activities surrounding transition, and then we can share resources and kind of create these new overarching projects. This brings me to the workshop that we did in February, which was our first big event. And the main aim here was to kind of establish these minimal criteria to help with continuity of care within this transition process. The first thing we did was found our ERN Youth Panel, which Aurora already mentioned. And so the aim here is to empower these patients and to make sure that their experiences are what drive us. Currently, we have, I think, 30 members, and we've made connections with Eurordis and Raising Voices and all of the ERNs. We've also made efforts to link them to the EPACs of the respective ERNs. Secondly, we did lots of preparatory work. So we did a survey with healthcare providers, we interviewed young people, and we also did a patient survey. And based on all of this, we kind of identified 4 main themes, each with 3 sub-themes, which we worked on during this workshop. So those were organization, psychosocial well-being, communication, and education. In the end, we had 84 participants, 22 European reference networks, and 16 European countries. So for the participants, it was a very varied bunch. I know some of the participants are here in the call also, so I'm happy to see your faces. But so we had healthcare providers, we had paramedics, we had patients, we had project managers, researchers, policy advisors, basically everything we could think of. And then for the countries, we also made an effort to include countries that are often not included within certain projects or research. I do not have the time to go very deeply into everything we did that day, but to be very brief, we used a service design approach, and we did 3 rounds of workshops. So in the first workshop, the idea was to empathize. So we put a lot of people together in subgroups of 5, and they were asked to think about, okay, for your specific topic, what is the most important aspect? We then made them go to a different room. So they then were presented with a list of everything that was important, and then they had to think about actions or solutions to these things. And then lastly, they were asked to further develop them into recommendations. We then kind of summarized all of that at the end of the first day. And then on the second day, we presented this, and we then had a panel discussion. And we've already also discussed this at length with the youth panel to kind of make sure that the outcomes are still relevant to the patients, and it didn't get lost anywhere along the way. So this brings us to the outcomes we have. I'm still writing the manuscript, but this is what we have right now. So the fundamental principles of transition in rare diseases across all the ERNs. Firstly, to establish contact between pediatric and adult services. This is very much the number one. It's also when we ask the patients to kind of rank them, this comes out as like the top thing. This is what we should do first. Secondly, to provide contact details and to discuss communication strategies. So making sure they know where to go and how to get there. Then to inform about future care. So again, this is about a little bit of preparation, but also kind of knowing that things might change and how to deal with that. To use transfer documents. So this is both documents for the patient as well as documents for the healthcare providers to just make sure that the information gets to the other side safely. So we've summarized this as providing information, and to offer psychosocial support and to offer peer contact. Both of those are summarized within providing support. And then lastly, and I think the most challenging, to integrate transition into education and training for healthcare providers kind of along their careers, so that it's not just a one and done, but that it is something that keeps being repeated. Brings me to this very busy slide, but I've kind of led you through it. So just to conclude, the most important things during the workshop really were like access to and continuity of care within this journey, and then to be able to have consistent information and access to mental health and peer support. And then lastly, when we talked about implementation, like as in a general way across Europe, time was the biggest barrier. So that's it. I don't know if you have any questions. I'll stop sharing.
Thank you very much, Jan. That was a super rich presentation. I don't know if there are any questions. You can raise your hand. Otherwise, there is one already in the chat. Will there be another workshop on transition?
It's a good question. It's something we're working on within the working group. And I think what we mentioned lastly is to really follow up on how this is getting implemented, because we don't want it to stop here. So I think the papers first, and then we're kind of going to work towards seeing how we can durably implement this.
Thank you. Anne Lawyer, please.
Thank you very much, Nora. Yes, Jan, and everybody. You mentioned continuity of care, and I always wonder, should we stop using the word transition and just use continuity of care, because there is so much research and papers and lots of attempts at transition, and they seem to fail. So continuity of care, I think, is far more appropriate, because our children are born with these conditions. So they're not really, for me, there was no transition. She just needed her care to continue. So yes, I just thought I'd say that. Thank you.
I think it's a wonderful suggestion, and I agree. I think we're working much more towards like integrated care and continuity, and I think transition is a relic from our research to kind of make sure that it can still be found in those realms. But I fully agree.
Thank you. Ines, please.
Yes, I have a very practical question for you. Since this is a cross-ERN initiative, which I find that is kind of wonderful, I was wondering, like, the workshop that you organized and transition, I'm assuming that, I know that you asked for funding, but everything now that has to do with this group, I'm assuming that ERN Liver is doing the heavy lifting, and everything comes from your budget, right? And I was wondering if you were exploring the possibility of having a common budget with other ERN so that you can share that burden in terms of financing. And I'm also thinking about the BIPCA's initiative, because you have kind of under your wing, you have the youth, but I'm wondering if any ERN could maybe have the aging working group under their wing, because this is really, I mean, things progress, I guess, when you come together. And I know that for sure, because Nora was in that workshop and she came back really very excited about it. So yeah, that's my question to you. Thank you.
Yes. So ERN Rare Liver is coordinating this group, which does come with some responsibilities and also a little bit more of a financial burden. However, for the workshop itself, also all the ERNs funded their own representatives. And with the upcoming grant renewal, it is also something we're working towards. We're also applying for funding. But yes, we're very much right now within the working group kind of creating subgroups and sub-projects, which are run by members of the core group who are very much not all ERN Rare Liver, because we do want it to be an overarching thing. So we've made lots of efforts towards that.
Thank you, Jen. If no more questions, I may have one as well. It's regarding someone who may want to be in contact or join the youth panel. Is it still possible? And another question, how are you connecting the youth panel with the EPACs in the different ERNs?
Yes. So yes, it is still possible. There is a general email. I'll share it in the chat in a minute, where you can kind of apply. We are trying to, again, making efforts to make sure that kind of all of the different groups of rare diseases are being represented, so that it is, for example, not 15 ERN rare liver patients. So we do kind of try to select a little bit on that. And we're just sending lots of emails to the EPACs. We're linking them. Some ERNs are differently organized. Some are a little smoother, some are a little less smooth. But so we've been working towards that, and I think we've made some good steps.
Thanks. So this is a clear call to please come together. Vivke.
As we all have problems to have new EPACs, this is the best opportunity to get young people involved who then stay longer. This is what we as EPACs in the rare liver just decided to promote more, because like that they get experienced and they are really experts when they're starting as EPACs. So that was just an annotation.
Thank you. I think it's a good idea. I don't see any more questions. I do see a lot of comments in the chat, so Jan, have a look to those. And with that, I would like to give the floor to our next speaker. He is Ines Hernando, ERN and Healthcare Director at Eurordis. And she will explain about the importance of measuring, so the use of indicators to support the implementation of transitions at practices at national level. Ines, I think you will share your slides. Otherwise, I can do it. You are muted, though.
Okay, I'm going to unmute myself first.
Yes, now we hear you, and
we see the... Yeah, but you see the full?
Yeah, no, we see the small ones.
Okay, now you see the full, no?
Yes, thanks.
Fair enough. Okay, sorry. Not used to Zoom anymore. Okay, so I'm going to give you a little bit of a teaser on indicators and how to measure the effectiveness and impact of transition pathways from the perspective of a health system. because I think it's really important that we are kind of aware that what we're discussing today, the transition specifically from pediatric to adult care, is really being prioritized across many national rare disease plans. So for another workshop that I had to do in Prague, we conducted a little analysis around across 7 rare disease national plans, and we looked at indicators. And when it came to looking at the ones on transition, we saw very clearly that across the 7 countries that we were looking at, so Luxembourg, France, Belgium, England, Italy, Spain, and Sweden, all of the national plans mentioned the ambition of implementing and developing this transition pathways, but only France includes a specific indicator to measure the effectiveness of the system. And England has developed a very specific quality standard for transition that also includes rare conditions, but it doesn't mean that it's being measured in England. It just means that we have a very nice quality standard with very nice examples of indicators that any country can use. So I don't know about the implementation, just to be clear, but I do know that France is actually implementing this one indicator on the transition pathway. So with these, I want to make sure that we understand that there's lots of things that can be measured when we look at measuring the impact and the effectiveness of a transition pathway. And these the English quality standard that was developed for transition, I think is a very nice framework that we can look at. So here you can see that we have 5 process indicators and 1 outcome indicator. So the process indicators are kind of very basic when you look at them. So if you think about, like, the first one is planning transition. So having a follow-up contact after the first follow-up contact, after missed first adult appointments, and immediate planning for late entrance. So they're looking at if there is a real planning in the transition for the transition pathway. Then they are looking at the coordinated plan, so if there is a coordinated transition plan in place, and an annual meeting, so an annual review meeting for transitioning planning, a named worker, so if there is anyone with a name and a surname coordinating care for the patient, and the only outcome indicator is this satisfaction with transition planning and transfer. And they're also looking at a pre-transfer meeting with adult service practitioners. And the 6th indicator they're looking at is if there has been any follow-up after non-attendance. So if a person misses the first appointment, if the system, let's say, or someone in the adult care center follows up with this patient. So, as I said, 5 process indicators and just 1 outcome indicator around satisfaction with transition planning. So why is this, and why is it so difficult to measure, and why do we have so many process indicators, let's say, there? So it really, even if the indicators look very simple and very obvious when you define them or you look at them, it takes a lot to measure a process indicator at a health system level, let's say. So first of all, looking at what France has done now, I'm forgetting about England, but looking at what France has done specifically, they are looking at they have 1 indicator, which is adolescent patients successfully transitioning from a pediatric center to an adult center without interruption of care. And the calculation of these indicator, well, I'm not going to go into the details there, but you need to have a good understanding of all the patients that have registered for a first outpatient consultation in a medical service center. You need to be able to count them, all of them, let's say, and within a time frame, say 12 months, for instance. And you also need to understand, in order to, again, do this calculation, what interruption of care means. So losing sight of the patient, let's say, and then if if you've lost sight of that patient, it won't enter the numerator, but it will go into the denominator. So just to say that you need to have a very clear understanding of what goes into the numerator and the denominator to calculate the indicator in order to information that you need across the country, which is quite difficult, let's say. So you do need a very strong IT infrastructure behind an indicator, let's say. And France does have this. So first of all, they have the rare disease minimum data set. So they've studied for this for a long time. So every time a doctor sees a patient, he or she is required to fill out a basic clinical data set. And they also have hospital interoperability to a certain extent, let's say. So hospitals dump data from their electronic health records into Bamara, and then they can centralize this in their Banque Nationale de Maladies Rares, and the ministry can assess what percentage of adolescents from the 23 rare disease networks that they have successfully transitioned and without experiencing an interruption in their care. So this is a process indicator which I've just described. And if we look at measuring outcome indicators, that is kind of the gold standard. That's what we want to know, whether the patient has experienced, a good transition, let's say. So for this and for other also areas, a research team in Ireland is developing now rare disease PREM, and that they are actually in the process of validating and they are actually piloting the questionnaire at the moment, and we hope that will be available in 2027. And in this questionnaire, there's one question on transition, and the question will be for people to reply whether pediatric to adult healthcare services was well managed, and whether the person living with a rare disease, the transition from pediatric to adult healthcare services was well managed. Because they will have two questionnaires, one for patients and one for carers. So the two questions there are one for the patient, if you're a patient replying to the questionnaire. The second one is if you're a carer replying to the questionnaire. So eventually, if health systems do implement this PREM at a health system level, so across the different hospitals and expert centers, they might be able to start measuring this at a population level. So to wrap up, because this is a very short intro, really, we do have good examples of process indicators, so we don't need to think about new, fancy things. Examples are out there, but the challenge really is to have the infrastructure to measure them at a health system level. So measuring these indicators at a hospital level, it's easier because of the scale. Just because a hospital is a smaller place where an IT department can collect the data, normalize the data, etc., and give you the quality team, let's say, the information to analyze. And on outcome indicators, as I said, this is the gold standard, but capturing the information has a lot of complexity, let's say, even maybe more than the process. Well, no, not even. I mean, yes, for sure, more than capturing data for process indicators. So we really hope that that healthcare providers and the health systems will start using the rare disease PREM once it's available. And the suggestion here is a very simple one, which is to start with a few good indicators and develop additional ones as part of any project. And you might ask me, what is a good indicator? So a good indicator, you have the characteristics of a good indicator there. The four main characteristics is that the indicator is valid, so that it measures accurately what is intended to measure, that is reliable, so free from substantial error or bias, sensitive, so it allows you to understand if there are any changes, and specific, so it should be expressed in really precise terms and attributable to, and you should be able to attribute any changes that you see to your project, your activity, etc. And then the criteria to select good indicators is that they are relevant, for the project or the objective you're aiming at, that they're objective, so that they are based on facts as much as possible, rather than on feelings, impressions, or opinions. That they are realistic, so that they're not too difficult or expensive to collect, and linked to that the data is available. So as I was saying, that you have that they're based on data that is readily available, or that can be collected with reasonable extra effort. So yeah, this is me, and I think that now we have the colleagues from the Central who are going to explain to us what they are doing at the hospital level on measurement. Thank you, Nora.
Yes, maybe before that, if there are any burning questions to Ines about what she just explained. So far, I don't see any questions in the chat. Please raise your hand if you have any. Okay. Then I guess, yes, we can give the floor to Edouard. Ines, you can stop sharing, and Edouard can start sharing his.
So, can you see the presentation now?
Yes.
Yes.
And can you hear me?
Yes.
Yeah.
All good.
Then we can start. Hi, everybody. We are Eduard and Esther, that she's in the virtual room. I'm social worker and transition coordinator, and Esther is the head of the transition and continuity care area in San Joan de Déu Children's Hospital. First of all, we'd like to thank Ines and Nora for giving us a chance to be here today and share our experience that I'm sure everyone will learn, and I hope we're the first ones. San Joan de Déu Children's Hospital is one of the leading pediatric centers in Spain. It's reflected by the figures shown on this slide. It's a huge hospital with a lot of surgeries, emergency visits, consultations. But over the past 20 years, we have become a reference center for rare disease in a local, national, and international level. We will continue expanding our contribution to rare disease care and research with the opening of a new center called UNICAS, who is dedicated to rare and complex conditions. Given the importance of rare diseases and the pediatric nature of our hospital, our quality department launched 10 years ago the ADEU program. ADEU means goodbye in Catalan language. And this program was created for structure and organize the transition from pediatric to adult care, healthcare. The program is built around 6 key pillars, and all of them are closely aligned with recommendations proposed by several ERNs and what Ines was telling just right now. The first one is structure and early planning. We aim to start transition planning early, usually between the age of 15, 16, or before, and we try to adapt the process to each patient individual needs. Second is the patient-centered and individualized approach, where patients and families actively participate in designing their transition plan according to their medical condition, to their personal circumstances and goals. Third is the patient preparation and empowerment through our case management team. Young people are supported in developing the knowledge, skills, and confidence needed to manage their condition, navigate the healthcare system, and access community resources independently. Fourth, the coordination between pediatric and adult services. We have established communication channels and collaboration agreements with other hospitals, while also involving primary healthcare professionals through the process. The fifth is a standardized transfer of information. We have developed a transition guide that is continuously reviewed, updated, and expanded to ensure a consistent transfer of information. And last but not the least, psychosocial support. We also provide a social guide covering the most relevant social, legal, and practical changes from young people that young people may face, particularly those living with severe disability or high levels of dependency on a caregiver. In complex cases, especially those followed by palliative care team, social workers act as transition coordinators to support patients and families through this process. To ensure the program continues, to reflect These principles, we regularly collect information through questionnaires sent to families after the transition process has been completed. This data allow us to monitor two types of indicators that Ines was talking about. In the one hand, we collect process indicators which track key transition goals, such as planning activities, assessment, visit, and documentation. We use Congo's platform, and we can also monitor continuity of care after transfer, such as timely appointments with adult healthcare services. On the other hand, we collect experience indicators, which capture feedback from patients and families regarding preparation, information, and care coordination. In this case, these data are collected through the Qualtics platform. In 2025, about 1,500 patients were transitioned to adult care, and about 60% of them were living with a rare disease. We would like to share some of the results collected over recent years, and this data help us to evaluate the program and identify both strengths and opportunities for improvement. Regarding the transition process itself, we generally see positive results across all the areas evaluated. Almost 60% of patients report feeling completely informed about the transition process. This percentage is slightly lower when patients are asked about their contact with healthcare professionals or team who will continue their care in adulthood, as well as about the practical changes in the adult hospital setting, such as laboratory procedures, pharmacy services, or care pathways. When looking at coordinator results are also positive. Families and patients report greater visibility of coordination between professionals within our hospital, while coordination with other hospitals is perceived somehow less favorable. Finally, we also assess experiences on patients have already attended the adult hospital, and around 75% describe their experiences as positive or very positive. The group we need to pay particular attention is the proportion of dissatisfied patients and families. Understanding the reasons behind their experience is essential if we want to introduce meaningful improvements. Some of the improvement actions we are currently working are based directly from these results. One priority is to further improve access to our transition resources, including our Know Social Guide, which will help families anticipate important processes that can generate significant stress and uncertainty, such as legal protection measures for people with disability. Another challenge is consolidating contact between patients, families, and the adult healthcare team before transfer takes place. To achieve this, we are promoting initiatives such as joint visits and other collaborative projects developed together with patient experience teams. Finally, we need to stratify and analyze the adult care experience data deeper. We would like to explore whether experiences outcomes are associated with factors such as sociodemographic characteristics, specific disease, or particular medical specialties. Applying quality indicators at an institutional level allow us to focus on everything that still needs improvement. And there is certain plenty of things that to keep improving. But at the same time, we try not to lose sight of something equally important, which is that even though there's still a lot of road ahead, let's not forget how far we have already gone. Thank you very much. Muchas gracias.
Thank you very much, Eduard. I see a lot of clappings. Do we have any questions maybe for Eduard? Hopefully it will inspire. Ines, please.
Yes, I have a question for Eduard, and he knows. I want to understand. I want to know how much are they able to really extract specific information on those red bars and the people that are behind, and the features of their transition journey, to understand, what are the kind of points that we can touch upon to improve things, and because it all looks very nice, but there's a couple of kind of things there that are not working as they should, and I'm wondering if they're just, things that there's not much you can do about it because it's beyond your control or the hospital control. Yeah, if you have any more information on that.
Actually, I have to thank you for giving us this idea, because when we keep collecting all this data, we thought that we have to start by the things that were not working. That was started 10 years ago. And with everything you want to change in this kind of processes, it took so long. Make changes inside the hospital was a very complex challenge to make the families change, the medical teams change, the nurses to create these coordinators of the process. And what you ask, I think it's very, very important that we can just focus more on that to stratify what kind of circumstances can make transition go worse. So let's say there are some neurological disease usually are more dissatisfied with the process, or maybe dermatological, I don't know. So I don't have the answer to that, Ines, but your question brings us more work to do. And I think it's key factor for our program to keep growing and improving every day.
I'm going to give you more work. What? Because have you ever thought about, because you are in the Catalan health system, and I'm wondering whether, because it's very nice if you happen to be, in the Sant Joan de Déu, being treated in the Sant Joan de Déu, then you have this program. But have you ever had any discussions at the Catalan health system level on whether, transition could be measured maybe based on some of your indicators, and how feasible is that? Because I understand that everything comes from your kind of level and then needs to be, but I'm wondering if there has been any discussions around that or anything.
Yeah, we have conversations with both the Catalan health system, and Esther is here to help me with this answer, because the Catalan health system, for ones who doesn't know, they have the specific rare disease area. And we have even been talking with politics, because a new law from palliative care is going to be approved in next month probably. And we've been in Catalan Parliament talking with politicians to put how important is transition, and to have other hands out from the hospital helping us to have this view from the mezzo level, and because we are focused in our reality. But I don't know if maybe you want to say something else.
No, we are working very closely with the rare diseases model from Catalonia, but actually the health system, the hospital have different systems. We have different culture, politics. We know that in Sant Joan de Déu we are so lucky because we have a patient experience department, process department. So we can go on and we take advantage about this. So we work closely with them in order to provide our experience, like a very specific hospital, because we are a pediatric monographic hospital focused in rare diseases, and also to provide some some requirements in order to set also adult health system indicators, because if we work very kind with willing with our professionals transition process in our hospital, when our patients goes through adult system, we lost the follow-up. So, and as I don't know who said, but the transition is not a transition, it's a pathway, it's a continuity of care, because we are working in many transitions in vital transition, adolescence to young adult. We are working health transition. We are working school transition, family transition. They are always in charge of this child, but now they have to become.
They need someone to take care of them as well. Father and mother are not eternal, so we have to even plan the future care plan.
So this is about continuity of care that involves many different systems. not only health system, but also school, social. So we need to work together and to bear in mind that the health is not only building in health system, it's also building in other systems. So I don't know if I'm right speaking English. So I think
no, yeah, it's very clear what you're saying. Yeah, thank you a lot. Yeah, because you're very right. Yeah, I understand. But if I were to, I'm going to push you a little bit further. If you were, to pick one indicator, like the French have gone, the French national rare disease national plan has picked one indicator, just one process indicator to measure across the country. If I were to ask you which one would that be in the Catalan health system or even in Spain, but I'm talking about the Catalan health system because that's the one you know and the one you're more familiarized with, and the hospitals, etc. If you were to say this one, we think everyone could provide the data, what would that be?
If you ask me, I would say something about the patient security at the beginning, that we are sure that there's not any lost in transition situation, that no one is losing a follow-up, that no one is losing a surgery that they need. That we know all the time where the patient is. I don't care if it's the pediatric hospital, the adult hospital, or the primary health center. But someone in the system knows where the patient is and what's next with that patient.
So it would be possibly the same one that France has. So transition without interruption of care, adolescents that have not experienced interruption in care.
Yeah, and from our perspective as a pediatric monographic hospital, one important indicator is whether the young people report feeling prepared for the transition to adult care, because we believe that this reflects the quality of our responsibility, that it's prepare these patients and families to dive into adult system.
Yeah, because sometimes you change you change the decisions based on how you see the patient, right? And how prepared
And because there are many things that are out of our control. I mean, I know I can will prepare our patients and families to face, to copy all these different situations that they are gonna find in our system, because as I said, the culture, the timing, the logical of the model of care are so different. So I think to prepare patients in a good way, good way is the best that we can do in pediatric care.
Thank you.
You too.
Thank you so much for these questions, Ines and Eduard and Esther. Do you have in the audience any more questions? We have time. So for the first time, I think in history, we didn't run over the agenda. We have time. Anyways, thank you so much, everybody. We have Sophie.
Yeah. I have a practical question. Like in Saint Jean de Dieu, like, are the patients always referred to as one specific adult hospital, or can they go to any adult hospital? How does that work? Like,
It's a good question. We have in Catalonia, we have a rare disease model. So these allow us to identify which is the best hospital to treat each disease. So sometimes it's tough because the same patient is identified in a different rare diseases that that belong different accreditations. So we need to talk between professionals with patient and family and consensus, which is the best hospital to transfer. And sometimes are two hospitals, primary care, and also involving a general hospital.
Okay. Thank you.
Okay. Does anyone else wants to contribute maybe? I see there was a vivid exchange in the chat. That's great. So if not, maybe I would like to thank all of you that are here today, all the participants, because to be honest, it created a lot of interest, this series of webinar. We've received plenty of requests to come to the webinar, and we couldn't accommodate all, so you can imagine. And also thank you to all the speakers of today's sessions for being here and sharing with us all their experiences and knowledge. For tomorrow, we have also planned another session. So as you saw today, the session was more structured in these different levels and how we can kind of approach and address some of the challenges identified through the identification of indicators. And tomorrow we will look more into what some of the European reference networks are doing in terms of practical tools and resources to support implementation in transitions. So we are focusing tomorrow on transition from pediatric to adult care, because to be honest with you, is where we found the most of activity happening at the moment. So we will have ERN Ernica, we'll have Caroline Love. She's IPAC lead in ERN Ernica, and she will explain about building capacity of adult services to receive transition patients. So it's a bit what the question you asked, Sophie, how to overcome this gap that we see sometimes in the adult services. We will then have ERNet. They are developing a transition passport for rare kidney disease. We'll have Karsten, who I think it's here with us today, and Simje, IPAC and project manager of ERNet, to present this initiative and how they are developing it from the perspective of the methodology. And then there is also an initiative developed by Rita and Reconnect. They are creating a transition of care course that it will be starting this summer as a summer course for different for patients, clinicians, and other healthcare services. And we will have Silvia, who is also here in the audience, and Moja explaining us about this initiative. So if you want to come tomorrow, please register, and see you tomorrow here. One last thing, when you close this webinar, you will be pop up with a feedback questionnaire. So if you have 1 minute, it's super short. It will help us because we also ask you about future topics for this type of webinar. So you can drop in there your ideas, and we will try to accommodate as much as we can. So I think that's it from our side today. Again, thank you very much, and I hope to see most of you tomorrow as well.